Good morning, everyone. I'd like to thank the program committee and organizers of this year's meeting for the opportunity to speak to you today regarding endo arch surgery. So I'll touch base on the history from open to all the endo arch options, minus the PMEG options that was already discussed by Dr. Petro. Here are my disclosures. Arch aneurysms comprise about 10% of thoracic aortic aneurysms and require greater surgical complexity, with consideration for cerebral protection during the operation management of brachiocephalic vessels. Arch aneurysms often extend into the descending aorta, so stage repair is often used, with an initial ascending arch elephant trunk procedure facilitating a subsequent more distal completion procedure. Arch aneurysms may be managed using several approaches: conventional open, hybrid, and totally endovascular. Hybrid approaches aims to reduce operative times. The aortic arch is reconstructed using an open technique proximally, combined with endovascular stent graft distally. Looking back at the history, the first successful aortic arch replacement was performed in 1957. Over the succeeding decades, aortic arch operations were done infrequently, with relatively high rates of mortality and neurological complications. Hypothermic circulatory arrest enhanced the safety of arch procedures, though there were still issues with distal anastomosis, hemorrhage, embolization, and thresholds for acceptable durations of cerebral ischemia. Hypothermic circulatory arrest with antegrade cerebral perfusion neutralized the impact of extended circulatory arrest period on death rates and stroke. Smaller, softer, and more flexible catheters for antegrade cerebral perfusion and improvement in cerebral monitoring have improved outcomes in open arch repairs. Trifurcated graft to aortic arch branch vessels avoids over-manipulation of diseased arch vessels and minimizes cerebral ischemia by enabling antegrade cerebral perfusion. Distal anastomosis can be brought forward for better visualization, decreasing circulatory rest time, and enhances hemostasis. Hybrid repairs involve debranching some or all of the brachiocephalic arteries and use standard tube stent grafts to exclude arch aneurysms. Totally endovascular approaches range from single branch devices for the subclavian artery to triple branch or triple fenestrated stent grafts to repair the arch. Hybrid and purely endovascular arch repairs are reserved for high-risk patients as short-term morbidity is reduced, their long-term durability is yet to be known, and there is the risk of stroke due to wire manipulation and embolization of air and/or debris. Principles of endovascular arch repair include: number one, complexity increases as more arch vessels are incorporated. Two, occlusion of the left subclavian to limit number of rerouted vessels. Three, use of extra branch from conduit for antegrade deployment of stent grafts. Four, antegrade deployment decreases risk of stroke. 5, transposition of left subclavian, left common carotid to brachiocephalic to lengthen proximal landing zone. And 6, endovascular stents can be placed either simultaneously or later in either antegrade or retrograde. The frozen elephant trunk device is a hybrid device containing Dacron graft attached to a stent graft, deployed in an antegrade fashion on direct vision. The stent graft covers the distal portion of the repair, and the proximal Dacron graft portion replaces the arch. More on the thorax graft. The thoracic branch endograft, or TBE, incorporates a single retrograde branch for arch vessel perfusion. Results from the U.S. pivotal trial published in 2022 resulted in the device's commercial approval, involved 34 sites, and reported one-year results of 84 patients with graft deployment in zone 2 and a side branch into the left subclavian artery. Technical success achieved in 92%, no aneurysm-related mortalities in 12 months. 3 other cohorts, namely traumatic transection, dissection, and other lesions like PAU and IMH, are being investigated, but published data is pending. The ascending graft was designed to close the dissection entry tear at the level of the ascending aorta and is the evolution of the thoracic branch endoprosthesis aortic extender for the ascending aorta. The relay branch system is intended for treatment of thoracic aortic arch pathology, including aneurysm, dissection, and IMH, requiring the coverage of the brachiocephalic and left common carotid arteries. The proximal end of the device is intended to land in zone 0. There is a large cannulation of fenestration leading to 2 antegrade internal tunnels. The right and left common carotid arteries in the neck are assessed to deliver the antegrade branches sequentially into the brachiocephalic and left common carotid arteries. Worldwide experience with a dual branch relay device has been favorable. On a multi-center data from Europe, looking at 148 patients who underwent treatment for arch pathology from 2019 to 2022, technical success was achieved in 99.3%. There was one mortality but was not thought to be device-related. 4% disabling stroke, 5% suffered a non-disabling stroke during the 2-year follow-up period. Reintervention was needed in 16.3% within 2 years, and branch vessel patency was 80% in the same period. This experience highlights the major use of endovascular therapy in the aortic arch, which is the risk of branch vessel occlusion and stroke. The Nexus aortic arch stent graft system is a single branch, 2-stent graft system implanted over a through-and-through guide wire from the brachiocephalic trunk to the descending aorta with an ascending aortic stent graft. The ascending aorta stent graft is deployed into a designated docking sleeve to connect the 2 stent grafts. Preparatory debranching procedure was performed in all patients with carotid-carotid crossover bypass and left carotid to left subclavian bypass or parallel graft from descending to left subclavian artery. The TRIUMPH IDE data was presented in STS 2024. The multi-arm, multi-center, non-randomized prospective IDE enrolled 110 patients from 31 sites. In the first 22 patients, it showed low mortality rate, no disabling strokes, paraplegia, and renal failure, and short ICU and hospital stays. The Zenith arch branch graft was designed to seal in healthy ascending aorta with either 1 or 2 proximal sealing stents and barbs for active fixation. The device can be manufactured with 2 or 3 inner branches. Standard deployment requires direct open bilateral carotid access and single femoral access, either open or percutaneous. But a total transfemoral percutaneous approach has also been described. A retrospective multi-center analysis of the first 38 patients showed 30-day mortality was 30% in the first 10 patients and 7.1% in the subsequent 28 patients, confirming the significant learning curve with patient selection and procedural experience. The study demonstrated reasonable results for total endovascular arch repair in high-risk patients. Various arch endografts available, of which only one is commercially available in the US. And these are other stent graft systems used outside the US. Challenges in arch device development are, number 1, safe and successful deployment of the endograft in the aortic arch caused by the angulation and non-uniform caliber of the aortic arch. Number 2, pulsatility of the ascending aorta and aortic arch. Number 3, the location and variation of the supraaortic branch vessels. Number 4, the distance of the femoral artery access site to the aortic arch. And number 5, the large size of the device delivery systems. We need to overcome incidents of endo leak, endograft deployment failure, branch vessel coverage, vascular access injuries, iatrogenic retrograde dissection, and unplanned secondary interventions. New frontier in the research include endografting of the ascending aorta alone versus with an aortic valve and cuffs for the coronary arteries. In conclusion, with increasing availability, experience, and options with endovascular techniques for the treatment of aortic arch pathologies, grows specially for highly selective patients not suitable for open repair. Further studies to demonstrate long-term outcomes are still needed. Thank you for your attention.